Welcome back to the Physical Therapy San Pedro podcast. This is episode 69, and today we're discussing rotator cuff injury, more than just a tear. I am your host, Dr. Janae Brown, and I'm joined by my physical therapy team. To the right is
Dr. Bay.
And to the left,
Dr. Silverton.
So guys, we are talking about rotator cuff injuries today. Shoulder pain is one of the most common complaints in the overhead athlete. We see a lot in sports medicine. And typically with a shoulder injury, athletes will ask, when they hurt their shoulder, did I tear my rotator cuff? They really worry about that mostly when they injure their shoulder. And am I going to need surgery? So our goal today is to sort of take you through the rotator cuff injury and kind of share with you that not always when you injure your shoulder, it's not always a rotator cuff tear. Sometimes there's just some tendinopathy going on. There's other things that can be addressed or be happening in your rotator cuff injury. So we want to understand or help you understand what the rotator cuff does, learn why injuries happen, discuss some treatment options with you guys for the rotator cuff, and explain how PT helps athletes avoid surgery and return to sport. So those are our goals for today's podcast, and we hope you guys learn some great and new information about the rotator cuff. We're going to start with going through anatomy today. So Dr. Bay is going to take us through what the rotator cuff is, not the rotator cup.
Or the rotary cup.
Or the rotary cup, as some would say. And what the rotator cuff does for us and helps us do. So Dr. Bay, take it away.
Thank you. When we refer to the rotator cuff, we're talking about 4 muscles and their tendons whose responsibility is to stabilize the shoulder. Since the shoulder is the most mobile joint in the body, it lacks stability. We always like to think of the golf ball in a T analogy. This part of the scapula, the glenoid, is the socket for which the shoulder sits. It's really tiny. And then you have the head of the humerus, which would be our golf ball. So we have a golf ball on a tee, very unstable. The muscles of the rotator cuff kind of suction it down onto its socket and provide that dynamic stability for it. So next we can go through the 4 muscles of the rotator cuff. This is a right shoulder to orient you. So turning around, this is the front side, the back side of the shoulder blade or scapula. On the top of the spine, we would have supraspinatus. It lives on the top of the spine of the shoulder blade, and it peeks through our AC joint. Its tendon comes through and down to secure onto the humerus. Next, we have infraspinatus, so right below the scapular spine or inferior to it. Teres minor, also on the back side. And then if we flip around and orient ourselves, this is the front side of our shoulder blade. The rib cage is directly in front of it. We have subscapularis.
Beautiful. Those are our 4, what we call sits muscles, SITS, sits muscles, and they sit on the scapula, essentially.
They are sitting on the scapula,
right?
Yes.
Hence sits. Very easy way for all you, physical therapy students and those learning muscles to keep that acronym for yourselves because it works. You'll use it forever, even 20 years after being a PT. So, Dr. Bay, what actual tendon is the most injured in the rotator cuff that do we see in our overhead athlete or just athletes in general?
Yeah, we talked about this on a couple of our other shoulder episodes, but the supraspinatus tendon that peeks out of the AC joint, that has a lot of potential to be compressed in the overhead position, and that's our most common injured tendon.
Why do you guys think that's the most commonly injured tendon? Why do we know it's the most commonly injured tendon?
Statistically, that's just what happens when they do MRIs and we find that, oh, hey, there's a tear right there. It's just most common. It gets a lot of load, does a lot of the heavy lifting as far as keeping the shoulder blade sucked in to there. Also does a lot of rotational motions when you go overhead as well. So it allows for that golf ball to spin on the joint. So the joint stays centered on the glenoid as the arm comes up into the overhead position.
Mm-hmm. And thoughts?
No, I agree with all that.
Yeah. It's also a tiny muscle. It's a little baby muscle that has to do a lot of work. So it's smaller than one would think, and then it has a big job. So I think that probably is it too. A lot of force in a small muscle. Okay, let's go into what causes rotator cuff injuries in athletes. Dr. Silverton, let us know, what are some of these causes?
A lot of it comes down to similar but related sort of things. Repetitive overload, poor mechanics, training errors, sudden increases in workload, not recovering enough between bouts of exercise or competitions. If you have mobility restrictions where you're having to rely more on your shoulder joint and not other parts of your body, and if there are certain weaknesses where it predisposes you to having to use your shoulder at a higher capacity, then you're going to be overworking it again.
Yeah. Any other thoughts? Anything, buddy? Any thoughts? Okay. Athletes most at risk. Which athletes that we see are most at risk for injuring the rotator cuff?
Overhead sports primarily. Throwers, where you're talking about baseball, softball, pitchers in particular, where they gain a lot of repetitions in, a lot of throws in. That's why there's a throw count now for Little League, so that way they don't overdo their shoulders at such a young age. Overhead, like volleyball, if they're on the front line, swimmers, if they're front stroke, or freestyle. Tennis, not as much, but they're still flinging the racket around and taking impact from the tennis ball. Football quarterbacks they don't have as much time throwing the ball, but that's still a good amount of their practice. Weightlifters sometimes will get a good amount too. They'll typically complain about it. It's typically not because they're doing a lot of overhead, but a lot of times it comes down more to either breakdowns in technique early on, or if it becomes a programming issue where they're progressing the loads too quickly and ego lifting sometimes. And then CrossFit, just because they get a lot of reps in under heavy loads. So you start seeing some issues come into play when, again, you're not programming for the individual on that end, or the individual is trying to keep up with the rest of the group.
Awesome. Have you guys seen a difference in the amount of male versus females that you see with this injury? Have you guys noticed any in clinic, not necessarily research related, but in clinic, have you guys noticed that you're seeing more male or female athletes with rotator cuff injury?
I would guess male from my clinical history, but I have no idea if there's a true correlation or
Yeah.
not.
And yeah, what about you? In clinic, have you noticed that you see one more of one or the other?
Nah, I'm not sure about that one. It might be an even split for me, at least anecdotally on that one. If I was to guess, more males, maybe just because they're more in overhead sports, more aggressive with the arms. Or if I was to guess why more females, not as much upper body strength relative to the males, so they might be more predisposed to injury on that case.
Okay. What about sport? Have you guys noticed in the clinic that you see a certain athlete that plays a specific sport that you're seeing more of these sports in practice? Either one of you?
I mean, we've seen a fair amount of swimmers with this.
I agree. Yeah, swimmers would be my number one,
Yeah.
probably. Yeah.
Swimmers, baseball,
Baseball.
tennis.
Mm-hmm. Baseball, tennis, swim. Yeah, I think I've seen a lot of swimmers. And then I would say, yeah, swimmers
And
and
putting water polo in with the swimmers.
oh yeah, that's true. All water sports.
Because I mean, that's throwing and swimming. But,
Yeah.
Or just beating each other up. I don't
Yeah.
know.
Yeah. And what do you guys think if you were to say the swim correlation is? What is it? Would you say a causation for that? Like for me, I would say probably load, like that swimmers are swimming every single day and they're swimming a lot of time and they're doing the repetition of the same thing over and over again. Do you guys have any thoughts? Any additional thoughts on that?
I mean, I'm not really a swimmer, but the reps they described to me for their warm ups and practice, it's a lot.
Yeah, agreed. And then last question I have for you guys is age group. Do you see in the athlete, whether it's from a youth, high school, college, adult athlete, is there an age that you guys have seen in practice more that struggle with a rotator cuff injury?
I don't think so. I mean, we've seen a good amount of high school and young adults. So,
Yeah.
A lot of the youth, I would say, it would lean towards that direction. Just mainly, I think, more the state of youth athletes these days and how much time they spend at practice and um, in the same sport between club and league, and that's more of a systemic sort of thing, as opposed to like they're just not getting any breaks between.
Yeah, I would agree. I think this is a problem in youth. It's one of the injuries that we probably see commonly because of overuse in the youth population. So, agreed. Cool. Good talking points. Just wanted to talk it out with you guys and what you see in clinical practice and bring it into the discussion, because what we see here sometimes looks a little different than what we talk about is or should be or whatever in research and things like that. Okay, let's go into rotator cuff tendinopathy versus a rotator cuff tear. So, many athletes hear the word tear and they panic, and I'm going to explain the difference between tendinopathy, partial tears, and full tears. So tendinopathy is just when the tendon is irritated. So you just have pain in the general shoulder region, and you're irritated, maybe pain with certain movements, and but you're able to pretty much function like below the shoulder level, and you can do most things, but when you move certain ways or you turn, maybe you're going to reach quickly overhead, you might feel some irritation in your shoulder. Typically that's what we would call tendinopathy. There might be some mild weakness, but that weakness is happening usually overhead, not below the shoulder level in general, unless, typically. Okay. So that's typically how tendinopathy goes. It's just irritated tendon. When we're talking about a partial thickness tear, you're having significant pain, probably more frequent pain, and you're going to have weakness, more significant weakness in that area. So you might have weakness in more motions below the shoulder level. You might have a painful arc moving through motion. You are going to usually be able to function, but your function is going to be more limited with a partial tear. And then with a full thickness tear, you have significant weakness. So oftentimes with a full thickness tear, you cannot elevate your arm, at all. Or you can elevate and move very minimally in lower ranges down here. But you are limited by your function will be limited. So you're not going to be able to lift overhead. You're not going to reach forward. You're probably not going to be able to sleep on your shoulder. You're going to have trouble getting dressed. You're going to have trouble with all of your function. If you have a full thickness tear, it will be pretty evident that is what's going on. You do have three other muscles in the rotator cuff besides the, potential tear that you have, unless you have more than one tear. So the muscles in the shoulder do coordinate together to help, but oftentimes not enough to get you to fully elevate overhead if you have a full thickness tear. So some of the things we hear when someone has a rotator cuff injury are, my shoulder feels weak. That's an indication that you might have a rotator cuff injury. I can't throw as hard. It hurts after practice. I can't sleep on the side of your injury. So that might be, those might be some of the things that you might be feeling. But that, pain doesn't always equal a tear. And the goal for us is to get you in to see us before it gets to that point. So we're going to talk about things that you can do, to help prevent you from getting to the point of a tear if you just have some tendinopathy. But those are the general ways to separate tendinopathy versus a tear. So now we're going to go into red flags and sort of when athletes should seek care. When do you need to go see somebody if you're having some shoulder pain and you're not sure what to do? So Dr. Bay is going to take us through that.
Yeah, some key symptoms we want to be aware of are persistent pain. Night pain is a big one. Weakness, loss of velocity for either throwing or pulling yourself through the water, loss of endurance, inability to complete your performance as you would have previously, pain with overhead motions, and overall decreased range in your shoulder joint.
So these are things that we want athletes to be aware of and be cautious of, especially parents, right? Because a lot of times these are things that, a youth athlete's going to complain to their parent about or their caregiver about, but, they may not know what to do about it. So essentially it's the parent that's going to need to be, aware of these things and know that they need to get some help. Why does playing through it, make things worse? Why should our athletes not just play through these things and, get evaluated?
Yeah, it's going to depend on the severity of the injury. But in general, if we keep re-aggravating the structures, they're just not going to have time to heal. So the PT, once evaluating you, can really assess what you are qualified to be doing safely and which things are going to continue to re-aggravate the injury.
Yeah. Also, tendinopathy is the beginning signs, right? But tendinopathy can turn into a partial tear or a full thickness tear. It's like a warning sign, in my opinion, that, hey, we're overdoing things. And if we keep doing that, we're going to run into a bigger problem, right? So you always want to act when it's a warning sign and not when it's too late and you have a very big problem, right? So go get some help if you have any of these key symptoms. I'm going to go into talking about, we talked a little bit about this in our last shoulder discussion, but I'm going to go into talking about why MRIs don't tell the full story. So, and this is one of our favorite topics because, MRIs are pictures and images of what's going on in the body, but we oftentimes will find that on an MRI, if there's something going on there, it's not always the end of the world, and it doesn't always mean that is truly the problem all the time too. However, and I would say in a youth athlete, if you get an MRI and there's irritation in the shoulder, there are signs and symptoms of tendinopathy. Usually we'll know if it's acute from an MRI, and usually you'll be able to tell if there's a tear from an MRI. So in this particular case, if you're suspicious that there is a tear, you can't elevate your arm, MRI is going to give you a lot of information. It is directly going to tell you that you have a tear there, a tear in one of the upper muscles going on, or tendon. But we just want to point out that you don't always need an MRI first. If you have pain in your shoulder, you can seek out physical therapy first. And if you came to us and you could not elevate your arm at all, we would be likely sending you out to a specialist, a shoulder surgeon, or a shoulder specialist, and we'd have, we recommend an MRI. So we're going to do that if you come into our office regardless. So you can always start with us. We're going to direct you to the right place, but oftentimes you don't need that. We can do some things right away to help you and avoid you from having to get an MRI. So my point is, if you're having shoulder pain, or you're a parent of a child having shoulder pain, you're an athlete that has shoulder pain, you can seek help first. You don't have to wait for an appointment with a surgeon or an MRI to make decisions about care. You can start care right away with a physical therapist, and we can help you and get you going, essentially. So we treat the athlete, we don't treat the MRI. So we're going to look at all the things that are going on with you that are limiting your function and your activity, and get you to start being a little pain-free and moving a little better. So regardless if you have a full tear or not, because you might have a full tear and you might need surgery, but we want to send you into surgery feeling good anyways. So PT is always a good thing with any injury. Okay, let's go into does every rotator cuff tear need surgery? A whole nother discussion. So let's say you have a tear, you have an MRI, it shows a tear, and you might thinking, I need surgery. I have a tear. I need surgery. Is that true, Dr. Bay? Does every person that has an MRI that shows that they have a tear, a rotator cuff tear, need surgery?
Thank goodness it doesn't. A lot of cases do not require surgery. PT, or physical therapy, can successfully manage tendinopathy, partial tears, and some thickness tears. The reason this is possible is because the shoulder, we discussed in the anatomy, the four muscles, but there's also the muscles of the shoulder, like the deltoid, the biceps, the triceps, our lats. We have all these upper back muscles. There's so many other muscles that almost give dual functionality. So for example, if you tear one external rotator, there's two more muscles that also assist in external rotation. If you tear supraspinatus, which is also an abductor, as Dr. Silverton had said, your deltoids can assist with elevation of your arm. So it really depends on how much function you're able to regain with physical therapy. And if you hit a stopping point and you haven't met your goals, there's a lot that can be done even, with injury of partial tears or full thickness tears.
Yeah, it's good. How do you guys help athletes make decisions regarding surgical intervention? If you had an athlete that came to you and they're like, I have a tear, how are you going to help guide them on making a decision towards surgery or against surgery? And thoughts?
Well, I mean, we have a series of return to sport tests, and for me, it's really, does it look like they're able to progress to the point where it looks like they will be able to meet that criteria again, so that we feel safe with them returning.
Mhm.
If we feel that they're plateauing and they're not going to be able to progress to that point, then that's where we might need higher intervention.
I would take them through the progressions. Early on, the decision tree doesn't really change too much if they have no range of motion. Then we're just going to treat the range of motion initially, anyways, before we're progressing into throwing. So that conversation can be benched to down the line, anyways, because they need to get their shoulder flexible to begin with before they're even throwing anything. So that's normally the discussion I'll have with them. It's like, tear or not, you got to be able to move your arm to get your arm over your head. So yes, I know you want to get back to throwing and whatnot, but you can follow up with a doctor, have that conversation with a doc to see if there is a tear, how significant it is, if it's going to impact your career, if you are aspiring for a college scholarship and things like that. Those are factors to consider as far as their participation in whatever it is they may be, or if they're just like a weekend pickleballer and it's like, oh yeah, I don't have to play pickleball, then okay, that's fine. You can have a tear and still live a very fulfilling life and not have any shoulder pain despite having a tear, because there's a lot of asymptomatic or non-painful shoulders that are positive for MRIs, are positive tears on the MRIs anyways. So it kind of depends upon the patient's goals, what their desires are, and then having that conversation with them to see how far they want to take it. And then comes down to the evidence that we have and the clinical judgment to see, and then take it as far as we can and see if the structures that they do have will support those goals for theirs.
Yeah. I think you covered a lot in that, and I agree with all of that. I think it just depends on what your sport is, what you're doing next. Do you have to go? Like you said, do you have a college scholarship? Are you in high school? Are you we look at all the different pieces and say, what do you need to do, and kind of help you make a decision based on what you need to do next and where you're at now. And so, like Dr. Silverton said, we just take all those factors, put them all together. And we're pro PT, but we also understand when surgery is indicated and needs to happen as well. We also know, research is showing us more and more evidence of when surgery is beneficial when we used to think it was, and it's not. So, or maybe you're going to have to, if you have the rotator cuff tear, guess what? And you have surgery, guess where you're back with us, back doing rehab again. So, the question is, what do you need to be able to do and how quickly do you need to be able to do it? And those are some of the things that probably impact some of our guidance and our decision making. But ultimately, you're doing physical therapy, and we typically like to take you through all the progressions, like Dr. Silverton said, first to see, are we hitting a stopping point? Is there a place where we're not going to be able to go any further? And that usually tells us you need surgery. Yeah. So, any thoughts, Dr. Bay, on that?
Yeah, that was basically, I had started saying that.
Yeah.
Like, we'll take you through and see if you plateau or not. Can
Yeah.
we get to your goals?
Yeah. If we have the time. And I think that's the question of, do you have the time to do that? Or is a time sensitive situation? So yeah.
Yeah, that's good to consider.
Yeah. Okay. We're going to talk about how physical therapy helps. So Dr. Silverton, what does great rehab actually look like?
So say we have someone that comes in day one, their shoulder hurts, they can't lift their arm, and they can't even get dressed. Well, they're very far away from sports or anything like that. Like I said, that conversation gets benched for down the line. First thing is first, let's get the shoulder moving in some degree that doesn't aggravate. So we'll normally break it down in ways where you're getting some motion on it without having to recruit muscles and get flexibility down. Normally that helps alleviate a lot of symptoms just because like being painful and staying in one spot really, really sucks and that hurts. Day one, we'll typically start with that as well as educating the patient on ways that they can alleviate symptoms as well. If they need support on the shoulder when they're sitting in class or driving or doing any sort of desk work, if they need to do any sort of self massage to help alleviate symptoms, ways that they can modify the things that they have to do on a day-to-day basis, so that way it doesn't keep bugging it so much. Teaching them positions of comfort so that way they can get better sleep at night, whether it's pillow under the elbow or whatever it may be. Whatever they come in saying that they can't do, we try to prioritize that so that way we're like, okay, let's just put the fire out so that way things calm down and starts moving in a more positive direction. After that, okay, get things moving. Sometimes the shoulder's just really so painful that they don't tolerate any sort of motion at the shoulder and they're just guarded, they're locking it up. Okay, let's move your neck then. Let's move your upper back. Let's move the other shoulder. Move your shoulder blade forward and back. So you're still getting relative motion of the shoulder, but it typically helps with getting calming sort of fears down. People get less guarded, and normally we'll find that when they say that they couldn't move their shoulder, that once pain goes down, they're able to start moving their shoulder afterwards too.
The question I was going to say, I would say a good point for us to discuss with you guys and tell you guys is the very first beginning parts of like phase one is like, it's a lot of education, right? It's a lot of like buy-in and getting the patient to agree to do the things that we're giving you to do at home, getting you to do your home program, show up consistently. It's a lot of education. That very first piece is where we spend the first couple of like weeks on just really getting you to do that. And I think that's really important because if you're not buying into what we're doing and you're not showing up for your appointments and you aren't changing some of the things that we're telling you to do at home, not doing things that are aggravating you, then oftentimes we see like the success rate goes down right in the beginning. So I think that's a piece that like I feel like a lot of therapists don't spend enough time on as the education piece in the first part of it, which is sometimes we don't get to the next phases with patients because they fall off because they're like, I don't want to do the same thing over and over again, or which you won't do with us. But I don't see the benefit here. So yeah, sorry to cut you off. Just wanted to make that note. Okay, so we've gone through phase one. We're calming down symptoms. We're starting to get moving in phase two. And then phase three. Talk to us about phase three.
We start loading the tendons. We start loading the joint. Starting on the light side, working our way heavier. Light can be even less than the weight of the arm, what we refer to as active assisted. So whereas active motion is just lifting the whole weight of your arm. Sounds remedial, but yeah, some people, you got to start there before you go any further because you go too far too fast, it hurts too much, and then they end up right where they have been. So we just break down the steps on it and then get things more tolerable, get things a little bit more acclimated, getting tugged and compressed on in the joint. Getting them to, if they have any, that's a good time to address any sort of mechanical issues, any sort of biomechanical issues, whether it's postural sort of things. That's a good time to take that step back and address that. Some that normally goes into conversations on how they're reaching, how they're lifting, doing things around the house. And that gets them more trusting of using their shoulder because, oh, it hurts when I pick something up with when I do it like this. But if they bring their shoulder blade back, it's like, oh, it doesn't hurt as much. Great, do it that way because then you can, pick up your coffee and it doesn't have to hurt. And it gives the patient a valuable lesson that, hey, you have control over that shoulder, and how much you make it hurt or how much you can make it not hurt. And then that lends itself to conversations as we continue the training. So that way, oh, hey, keeping that shoulder blade back when you're reaching the coffee, same idea when you're doing a bench press. Keep that shoulder blade back and push the barbell up or push the dowel up, depending upon how far back we're starting on that end.
So we've reduced pain. We've started to move everything. We're getting stable. We're getting a little stronger. We're developing control in the shoulder. Then we want to bring in everything else. So talk to me about phase 4.
Then we start expanding the scope of what we're looking at. Once the shoulders being well managed as far as range of motion, they're able to do the day-to-day sort of things. We are almost always keeping an eye on the rest of the kinetic chain as far as like what's their upper back rounding look like. Are they able to bring in their thoracic extensors? Are they bringing in their scapular stabilizers? Are there issues as far if they're a thrower? A big thing is getting power through the hips when they're throwing as well. Trunk rotation, trunk stability. We keep an eye on that stuff, but when we actually start building that into the program kind of depends upon where they're at in the program. But those are things that do get addressed. If not earlier, then at that point, once the shoulder's well managed and they can do the day-to-day things, then we're starting to look at, okay, more performance and being able to do the bigger things in life, whether it's starting to throw or starting to lift weights again, or picking up the heavier like bag of dog food from underneath the grocery cart.
Yeah. So we're moving into phase 5 now, which is like working on more bigger strength, power, plyometrics, sport specific progressions at this point if the patient is going back to a sport or recreational activity. And then we would be done, I guess, at that point. So we've gone kind of brought them to the end of that. Do you guys have any thoughts about, we talked about the last time, the phases that you feel like people struggle in? Maybe a phase you feel like people struggle in of these phases, or that maybe you struggle in as a PT with your patients?
I mean, just getting them to stay till the end.
Yep.
A lot of times when they feel good, they leave, but we haven't completed what we're doing with them.
Yeah. I had a patient this morning, not a rotator cuff tear, but just an athlete of ours that, had an injury. We were doing really good, pain-free, and then stopped coming to PT, then re-injured, now has a worse injury, needs an MRI, has more problems. So, and it's really hard because I think even though we spend a lot of time educating our patients, people need to be willing to receive that and want to commit to it. And it's a hard thing because athletes are young and they have a lot coming at them. And you guys are, if you're an athlete watching this, you want to do your sport, you want to participate in what you want to participate in. So I understand that sometimes some people have to learn the hard way, and get re-injured or end up, we have another athlete that injured their shoulder and it started off as a mild thing. And then they ended up they re-injured and got surgery. So sometimes we find that it happens that way. Our goal is to educate the heck out of you, harass you, and make you consistent and show up for your appointments and buy in early so we don't have that problem. But sometimes it doesn't work. But we are trying to avoid that from happening. And I agree with you, Dr. Bates. It's getting people to just stay through the end, get to the place where we're doing all the return to sport testing and you're passing your tests and we can truly have a good clearance and clear you. That is our goal. That's like a good rehab. What do we say when we're graduating people?
Fairy tale.
Yes.
Like a rehab fairy tale.
Yeah, rehab fairy tale. That's right. Excellent. Actually, yes. Okay. thanks, Dr. Silverton, through taking us through all the phases and what we're doing. I'm going to go into return to sport testing. Essentially, return to sport testing for the upper body is strength testing, functional testing. We're testing your movement quality. We're looking for symmetry. For return to sport, we're looking for around within 5%. Symmetry is our goal, but sometimes we'll clear you if you're below 10. It does just depend on the athlete and the sport and their age, all kinds of things. But our goal is to have as much symmetry as possible. And then we're going to make sure that you can do all the things you need to do for your sport. And sometimes we can't carry those things out here. We don't have a swimming pool and clinic, but we will guide and advise you on what you need to do and help you as best as possible go back to your training loads appropriately. Because this is where we get into some difficulty too with our patients where they re-injure. And that's why rehab is not always linear. It has a little bumps because we might have you try something that your shoulder is not ready for. And we got to take a step back and then we got to go back forward. But the goal is to make that, more of a linear curve and less of a bell curve. And you're always going upwards versus coming back down if we do things right. So, we want to make sure you're cleared. We want to have you return to sport, and we will do all the tests here using all of the objective measures we have, our ForceDex, our Dynamo. We will take you through as much of the things to replicate your sport in our clinic and guide you to the things that you need to do on your own. So that's what we're doing for return to sport testing. And I think essentially we're done with most of the podcast. We're just going to answer some questions together and then we'll wrap. So, what do you guys think the biggest rotator cuff myth is? I think it's called rotator cup or rotary cup. That's the biggest myth. It's not. It's cuff. CUFF. Rotator cuff. You guys have any myth?
Just because you have a tear doesn't mean it's painful, or that's the pain generator. Other things could be painful. You could have had that tear beforehand already. But it may predispose you to other shoulder issues. But just because you have a tear doesn't mean that that's the only thing to focus on, and that's the only thing that needs to be fixed. So.
Agreed. What's your favorite shoulder exercise, Dr. Bay, for the rotator cuff?
I really like wall ball type exercises because they do a lot. It integrates the core, deals with reaction. It's a little bit more like a real life stress.
Yep. You have a favorite exercise?
Weight bearing things through the shoulders. A lot of the running sports are open chain. They're slinging their arm around. But being able to bear weight through the shoulder compresses the joint, challenges the serratus anterior, any sort of shoulder winging, helps with a lot of stability.
I love multi-angle isometrics. I feel like you should be able to hold isometrically at every point that you need to move into. So I'm big on that, and I will manually take you through every area of and every angle that you'll have to move in, every pattern that you need to move in, because I feel like that is important. So that's my thing with the shoulder. What do you guys think the most overlooked area in shoulder rehab is? What do we overlook as physical therapists? What are we missing and not doing?
Joints outside of the glenohumeral joint. Or AC joint sometimes can be stiff. Thoracic region can be really stiff and tends to overclock the shoulder joint. So when in doubt, something I will check there also, just to make sure that that's not contributing to it.
Okay. Dr. Bay, anything?
I mean, I'm a big fan of starting at the core and proximal stability. So, the shoulder is attached to the rib cage, and the rib cage is on top of the pelvis. So sometimes I just feel like people's body mechanics in general, from the bottom up might be driving poor shoulder function.
Okay. And I think the most overlooked probably area in rehab is education. I don't think PTs do a good enough job of talking to their patients, asking them what's bothering them, asking them what they've done from the last session, adjusting their home programs to be appropriate for what they can do at that point in their programming and just having conversations. I think a lot of things get missed, and education is so important because our patients are only with us 2 to 3 hours, in a week, and they're by themselves so much of the other time. So we can save a lot of problems if we just have some discussions and talk to our patients and make sure that they're not doing things we don't want them to do, or being encouraged to do things they're not ready to do. So because people are people and we just want to go do what we want to do. So I think education is missing. I'm big on that in practice. So that's my thing with rehab for the shoulder and in general, probably in general. Okay, let's do a final takeaway. Dr. Bay, if you would like to, is there any final message that you would want to share with athletes or parents of athletes having rotator cuff injury?
Just to really intervene early. We went over those list of symptoms to be watching for. And if you see those starting to pile up with your youth athlete, do not hesitate to come in for an evaluation.
Yep. Dr. Silverton, anything?
Similar. Just because you have pain and you're in a throwing sport doesn't make that a normal thing. Get it addressed earlier on, and then you will have much less of a journey to get back to performance afterwards.
Yeah, it's good stuff. Don't ignore it. It's simple. Sometimes it's a simple thing that we can give you, or simple things you can do on your own, and you don't need to see us forever. So don't ignore your pain. Get help quickly. If you are struggling with shoulder pain and you need some help, we are here in San Pedro. If you're in San Pedro, we treat our clients in clinic, and we also do telehealth. So we can see you across the world. If you need some help or you need some advice or some education, we got you. Reach out to us. You can contact us through contacting us directly through our phone line, email us, go on our website. You can catch us through social media at Physical Therapy San Pedro. You can find us in a lot of places. If this is your first time tuning into this podcast, we have 68 other episodes that you can go tune into. You can watch them on YouTube at Physical Therapy San Pedro. You can listen to them on your favorite podcast that you are driving down the road and listening to. So Spotify, Amazon, Apple Music, we're on it all. And we are wrapping the shoulder today. So we're moving into our next joint. So stay tuned for that. Thank you for tuning in, and we will see you guys next time. Bye.